This one?
Mm-hmm.
Okay.
Okay. Yes. Okay. Good afternoon, everyone. Looks like it's 1:35, and I guess we start on time. Hope everyone had a good lunch. This session, my pleasure to be here and co-host it with Dr. Albert Koong, and we have a few cases. The session is entitled Challenging Cases and Technologies, looking at MR-Iinac and protons for GI cancer. So we have 3 cases. I'll present 2 of them, and then I'll have Dr. Koong come and take over for the 3rd case. When I designed these, I thought maybe there's like an audience response system, so I put in some questions, which I guess we don't have it. So I don't know if people want to raise their hands. I'd be just always curious to know how people answer with these types of situations. Okay, so disclosures. Okay, first case. This is, what is the appropriate preoperative therapy for gastroesophageal cancer? And this is an area that's undergone a lot of changes recently, and I'd just be curious to know kind of what people think about for a case like this. So this is a 61-year-old man, presents with dysphagia for 4 weeks, 15-pound weight loss over 3 months. Patient's generally well, able to tolerate soft foods and liquids, 20-pack year smoking history, but also social drinker, has a history of reflux disease, which is very common in the United States. Otherwise, physical exam is good, everything else looks good. So then patient gets an EGD, shows a friable obstructive mass at 33 to 36 centimeters from the incisors. Biopsy was done revealing a moderately differentiated adenocarcinoma, and that is still the most common type of histology that we see in the West. And endoscopic ultrasound shows that this is an T3N1. And a PET scan is done, and basically you can see the primary tumor here. It's supposed to be right there, and then there's the PET positive tumor. No metastases, but they do show that if you look a little further up, where's the crosshairs? I think right around here there's a little PET positive lymph node, so distant from the primary. And then if you go a little further up, it doesn't show up that well, but there's this very faint positivity right there in a kind of an upper paratracheal region too. So Mike, I guess the questions I have are, what would be your treatment recommendation for this patient? Chemo radiation, followed by surgery, followed by nivolumab if residual disease. Chemotherapy, followed by surgery, followed by chemo, so perioperative chemotherapy. Chemo, followed by chemoradiation, followed by surgery, and then maybe more chemotherapy. Chemoradiation and observe if a complete clinical response, or surgery and then chemotherapy. Who thinks number 1? Anyone want to raise any thoughts? 1? Okay. How about number 2? Okay, a couple folks. How about number 3? Number 4? And number 5. Okay, so it sounded like both were between 1 and 2, and I would say that, that does not surprise me at all. So just to kind of go through the background here, these are some of the data that we've really relied on. I think the main one to focus on probably is the CROSS trial. That is the trial that really has established chemoradiation preoperatively as a standard of care. But also just want to point out that there was this study, the MAGIC trial, that was primarily a gastric cancer trial that really showed the benefit of perioperative chemotherapy. It was mostly for stomach cancer, but a significant number of patients in this trial were lower third gastroesophageal as well. So for a long time, CROSS has been sort of the standard of care in I think actually pretty much everywhere, but definitely in the United States and in the Western world and Europe. But then the ESOPEC trial was presented, and kind of the ESOPEC trial was designed and has sort of been moving ahead during this time. But in that time, I think a couple important trials had come out. The FLOT4 trial, which was primarily a gastric cancer trial, but included a significant number. I want to say it's up to 40% of patients included were gastroesophageal cancer. And they tested perioperative FLOT chemotherapy versus MAGIC, which was ECF chemo. No radiation, just pre- and post-operative chemo. And it showed improved survival of FLOT over MAGIC, so that was considered standard of care. There was the Checkmate trial. This was the one that established adjuvant Nivo for residual disease, and this showed an improvement in, I think I lost my laser. Can you see my mouse? No. Okay, well, we'll try to do it without the laser. Adjuvant nivolumab for residual disease, improved disease-free survival. Neo-Aegis, this was presented in 2023. Now, this was testing really, this was been the debate, is what about perioperative chemotherapy versus preoperative chemoradiation? Which one is better? And people would use FLOT4 to justify perioperative chemotherapy. People would use cross, obviously, to justify preoperative chemoradiation. So the big question and debate was which one is better. And for a while, they just said, well, both are probably fine, but Neo-Aegis was the first one to really test the two. And it showed no difference in overall survival or progression-free survival. However, it's important to note that when Neo-Aegis was designed, they used ECF. They didn't use, or ECX. They did not use FLOT because FLOT had not yet come out. When FLOT did come out, they allowed the protocol to include FLOT, but only a small number of patients, I think like 20 or 30% of those patients actually had FLOT. So the trial showed no difference. Then the other trial that came out just recently, although I would say, okay, good, perfect. ESOPEC actually was presented right here. It was presented at ASCO last summer, and we already got the results of it. But Top Gear did come out in the New England Journal of Medicine in September, and it was presented at ESMO. But this was a trial we've been waiting for a long time with gastric cancer. What if you combined chemotherapy, chemoradiation with perioperative chemo? And this trial was asking chemo, perioperative chemo, or chemo followed by chemoradiation, then surgery. And so that really became the question, but it looked like the addition of chemoradiation did not improve outcome, no difference in overall survival, progression-free survival. And there was an improvement in pathologic complete response rate, but not really much beyond that. So so again, the background with cross, we all know this, is the improvement with preoperative chemoradiation over surgery alone. The difference was greater between squamous cell versus adenocarcinoma, but it was, seen as sort of a standard of care for both. Now, the ESOPEC trial, again, we'll talk a little bit more about this one specifically, but this was basically cross versus perioperative FLOT chemotherapy. So the difference here is that now all patients get FLOT, which is the best chemotherapy, and this was the trial design. You can see, okay, sorry, my laser doesn't work. Top is FLOT. You get pre and post surgery chemotherapy or cross. Standard cross 41.4 gray with carbotaxol. And this is the patient enrollment. It was pretty well balanced. Generally speaking, I would say that these were exclusively esophageal, gastroesophageal adenocarcinomas. But so this did not include squamous cell carcinoma patients. Patients were locally advanced. So they had to have T1 N positive or T2 to T4A with or without lymph nodes. But it's kind of important to point out that, we'll compare how these patients compared with cross in a second. But this is the consort diagram. Patients were randomized, to either perioperative chemo versus chemoradiation. How things turned out, you can see 87% of patients finished all 4 preoperative cycles. On the cross arm, the vast majority of patients, 98.5%, received at least 95% of the radiation dose. When the time of the abstract was presented, there was a lot of concern that the compliance rate wasn't as good in the cross arm, but you can see that as far as radiation dose received, it was actually quite good, and about 85% of patients received at least 4 cycles of chemo. Not surprisingly, perioperative FLOT is toxic, so a lot of patients are not candidates to get perioperative chemo or perioperative FLOT. So you can see that just a little above 50% of patients completed all 4 cycles of postoperative chemotherapy. So these were the results, and they were quite surprising, but it turned out that survival, which was their primary outcome, favored FLOT. It was statistically significant, and it is quite dramatically so. So very different from the Neo-Aegis trial, which showed no difference. And if you look at the multivariable analysis, the benefit with FLOT was particularly in younger patients. These are patients that are healthier, more robust, more locally advanced tumors, T3, T4, and node positive. So for these high-risk patients, it seemed like perioperative chemotherapy is better. Secondary outcomes, no difference in R0 resection. The path complete response rate actually favored FLOT, although this is a bit curious because if you remember from the cross trial, for adenocarcinomas, the complete response rate should have been around 23%. So for some reason, the cross arm underperformed with respect to pathologic complete response. Similar YP stage for both. And then if you look at patterns of failure, I mean, it is true that patients that did not get radiation did have a numerically higher number of isolated local regional failures. But again, that did not translate into improvement in survival. In terms of toxicity, again, there was an increase in toxicity, particularly with diarrhea and with neutropenia. And that's not a surprise. Again, this is a toxic treatment, but most patients were able to get through most of the therapy. And then this is just how we compare the outcomes. Let's see if So here is the FLOT arm of Isopec, here is the cross arm of Isopec, and then here's the cross patients from the cross trial. And you can see for the most part, most of them are reasonably well balanced and similar. You can see that there were more patients that were node positive in Isopec than there were in cross, so maybe a little bit more locally advanced. Again, the path CR rate was a little bit different, so unclear why that part underperformed. But again, the outcomes were relatively similar. So in practice, many people, we might say, as far as limitations, 41.4 has been the cross-trial dosage, but I think in practice many of us would go to 45 or 50 gray, so perhaps that extra dose could improve outcomes and improve path CR. Why was there an underperformance in the cross arm? The authors cite an inclusion of more clinical T4 and bulky tumors, though there were also more clinical T1 and T2 in Isopec than cross. So, for the non-Olympic, super healthy athlete patients, they may not be able to tolerate FLOT, and others will progress on FLOT. So the question is, what's the role of preoperative chemoradiation for these patients? And these maybe, preoperative cross may still be considered standard of care. These results do not apply to squamous cell carcinoma, which I know is something that we see quite a bit still in Asia. So we would not necessarily say that perioperative FLOT is what we would do for these patients. And then, of course, the other big thing is that cross alone is not the standard of care. Because of the Keynote trial, adjuvant nivo is used, and with the perioperative FLOT setting, we don't have data yet on what post-operative nivo added to a perioperative regimen would look like. So that is, I think, still to be determined. But I would say that after this trial came out, in our institution and maybe in many others, the treatment switched to perioperative chemotherapy, and we only use now preoperative chemoradiation for specialized situations where patients may not be surgical candidates or they cannot tolerate the FLOT chemotherapy. I think one question remains is, what if they're poor responders, right? After 2 cycles and the cancer progresses, those types of things, or they're not tolerating the FLOT. Would you switch them to chemoradiation, or would you take them to surgery? Those are questions I think we're all trying to figure out right now. Interestingly, I still think that there may be another role that we could play, and this is actually very similar to the rectal cancer story that some of you have heard about, we talked about this morning. But there is a push to move radiation out of the picture, but I think the other question is as well, can we move surgery out of the picture? And this is the Sano trial that was presented at ESMO a couple of years ago, was actually just published in the New England Journal. I didn't update it, or tried to update it, but it was published in the New England Journal about 2 weeks ago. And this was basically an active surveillance trial of patients, both adeno and squam were included, but basically patients received chemoradiation, and then for those that had a clinical complete response, they were randomized to observation versus surgery. And you can see what they found overall was that there's no difference in overall survival with this approach. So actually a lot to be learned about this. I think there are more trials coming, and I think this will be very interesting to keep an eye on. So where do we go from here? I'd say consider cross in poor responders to FLOT or FLOT ineligible patients. Can we promote organ preservation with a total neoadjuvant therapy approach that you hear about with rectal cancer? There are 4 major randomized studies testing surgery versus surveillance after chemoradiation. I mentioned Sano, but there's 3 other trials that we're waiting for the reports on. I think it's especially promising in squamous cell carcinoma, where we know there's a much higher pathologic complete response rate. In fact, many in practice are already offering watch and wait for these patients, and it's actually allowable in some of the U.S. guidelines. And I think big picture-wise, the role of radiation probably is moving away from the upfront curative therapy for esophageal adenocarcinoma, and it may be shifting more towards like an oligometastatic situation. And there is a lot of emerging data for the role of radiation in the oligometastatic disease setting. So I think the answer, my answer to this case was number 2, which was perioperative chemotherapy, and that's what our institution would have offered. And then I was going to go into a big discussion about like, oh, what do you do about the fields and all that stuff, but ultimately, I don't know what people would have done given all those nodal disease, but this is how I wound up treating this patient. I couldn't ignore this lymph node, and then the one that was up here really bothered me, and I felt really bad about ignoring it. And then the question is as well, I didn't feel comfortable not treating all the mediastinum in between, so I wound up coming with a very large field. I was able to get this to 45 gray and boost the gross disease to 50 gray, all in 25 fractions with a simultaneous integrated boost. And that's how the patient was treated, had surgery, and ultimately developed metastatic disease about 2 years later, but no signs of local regional failure. And I think this was before the Checkmate trial, so I don't think he received an EVO.
Was it concurrent?
It was cross, yeah. So that is what I have for the first case. And I guess, maybe it'd be good just to have some discussion about it and see what people think about any aspect of this. I guess, has the standard of care, I don't know if you know, Albert, it's more of a thoracic situation, but, have you flipped the switch to perioperative chemo? The role of radiation, is it still preoperative? I'd be curious to hear how things are in Taiwan.
I guess I would just say at MD Anderson, the approach generally has been, although I'm a GI radiation oncologist and I used to treat a lot more esophagus cancer at Stanford, our practice at MD Anderson is that the esophagus cases are more taken care of by our thoracic radiation oncologists. But I still have got to some of these tumor boards and discussions, not as actively involved, but the practice has been perioperative chemo for a while. So this case, I suspect, would have probably started with some amount of chemotherapy, and then probably restaging. If the patient does okay, then plus minus whether
Right.
this would have gotten chemorads.
I think the other argument you could use is I think with the burden of nodal disease, that probably is higher risk for metastatic disease, so using perioperative chemotherapy probably would have been a better approach or more preferred. The patient was, decent performance status, so surgical candidate. I think what it really comes down to is, it kind of changes the way we manage the patients, because usually the patients will come to the radiation oncologist or the medical oncologist. The surgeon may not really get involved until later on anyway. But if you're really going to think about a perioperative approach, you really need the surgeon to say right up front, is this person a surgical candidate or not? Because if they're not, then it completely changes how you want to treat this patient. So it's very important now, at least for us, we now have to rush them to make sure they get in to see the surgeon in order for us to know what to do. And then that can be challenging too. If you're a patient that they come to you and they have a hard time swallowing, they're losing a lot of weight and very sick, you don't have a lot of time. You have to make a decision pretty quickly in order to start get the patient under treatment as quickly as possible. So those are some of the practical situations that we've faced trying to make the switch over to this.
This patient get surgery?
Patient did get surgery, and they had to shop around a little bit to get it, but they wound up getting surgery. Any comments or any thoughts or questions? Anybody want to provide the Taiwan perspective?
We are kind of struggling recent because medical oncologists propose the data that you just presented, and as for the perioperative chemotherapy without radiation. But finally, the surgeon operated on the patient and found it was not easily removed because the response was not very good.
Mm-hmm.
But that's now the debate. But sometimes the surgeon just directly refer the patient to me, saying that, oh, this big tumor would not have the good enough response by
Right.
chemotherapy.
Right.
So what would be the situation in your side?
Well, I'm trying to think of a situation like that. I will tell you first off that the medical oncologists were not like really happy about ESOPEC because they don't love FLOT. I mean, FLOT is not a fun chemotherapy to give. So we have some that really don't like it, and they look for any reason to give to radiation, like, oh, they got a little bit of heart disease or a little bit of like high blood pressure. Maybe they're not good for FLOT. So we still get these referrals. In terms of like, we haven't yet really encountered too much about what if they're a poor responder in the middle of FLOT yet. I haven't seen that case situation come up, but we've discussed what we would do. And I think there's a bit of a differing opinion on the medical oncologists. Some think, well, let's just take them to surgery because the chemotherapy is not working if it's still resectable. So some would do that. Others are thinking, like, maybe you should reduce the dose of FLOT, and then see if you can get them through and complete all 4 cycles, then get them to surgery. And then others are thinking, well, I'd rather just send them to chemoradiation because I want there to be maximize the pathologic response. So you're kind of getting quite a bit of opinion on this.
Jason, what would you guys do if this was squam? You treat it definitively?
If it's squam, definitely preoperative CCRT.
Would you offer watch and wait if they're healthy for surgery?
Our surgeon does not like this way because they have the golden timing for surgery.
Yep.
So that's their challenge.
Yep.
If they miss that golden period, if any progression demanding the salvage surgery, that would be a problematic surgery. Yeah.
So let's say it's not a surgically resectable case. You have to use chemorads definitively. What dose would you take this to?
Based on the trial, at least 50 gray, but now we sometimes do the simultaneous boost to like 55. But I won't go up to simultaneously 60 because we don't have the data to support the better survival outcome.
Right. I mean, we don't really have much data to go above 50. So a lot of places have just stopped at 50. I've started to stop at 50 because I was just like, I mean, 54 is easy, but I don't really know why I do 54. So, I feel like many places have just gone to 50 gray now, which is why I do both preoperative and definitive now to the same dose of 50. Okay, well, if anyone, any other comments, happy to take them, but we can move on to the second case. Case 2, boosting the efficacy of radiation for pancreatic cancer. I'll kind of go through this quickly. 58-year-old man presents in the emergency room with a 1-week history of worsening painless jaundice, weight loss, loss of appetite, well-developed otherwise, physical exam supports some mild jaundice. Patient, you check them out, they definitely have scleroricterus and all the kind of standard physical exam findings for jaundice. Labs shows that elevated bilirubin, mildly elevated AST, ALT, ALK phos, and CA19-9. Ultimately, a CT scan is done, and here is the tumor. And you can see this hypodense lesion, and it has, at least 180-degree contact with the SMA and the SMV. And, the patient is, needs to know what the next step is. And of course, here are our treatment options. Assume no metastases, and the patient is otherwise a surgical candidate. Would you offer surgery followed by adjuvant chemo, chemo followed by surgery followed by chemo, chemo followed by radiation followed by surgery followed by chemo, or would you do chemo and then radiation only without surgery? This one, I don't know if this one has really a right answer, but I'm just curious to know what people would do. Anyone would do number 1? Number 2? Okay, yeah, that's not surprising. Number 3? And number 4. Okay, I agree. Most of them were number 2 or number 3. But obviously, we want to talk about how do we make this part. We want to talk about that one right there. So, a few questions to follow up with. If you offer radiation, let's say we go with number 3. Would you offer standard chemoradiation, 50.4 gray at 1.8 gray per fraction with 5FU? Would you offer stereotactic body radiation with a standard Linac, 33 to 40 gray? Would you offer MR-guided, SMART, SBRT, 50 gray and 5 fractions? or would you do hypofractionated radiotherapy 67.5 in 15 or 75 gray in 25 fractions? Number 1. Number 2. Oh, man. Number 3. Okay. And number 4. Okay. And then my last question is, if you treat with hypofractionated or SBRT, which everyone raised their hand and said they would, do you include the elective nodes? Yes or no? Who says yes? Who says no? Okay. All right, good. Some good discussion here. All right. So I'll jump right into the elective nodes. When Albert, the pioneer of SBRT for pancreas cancer, is sitting right there, Dr. Albert Koong, and he developed this, and I happened to kind of join in early. But the principle at the time was you want to treat as little as possible tissue, right? Because you want to keep the toxicity to a minimum. This was really crazy at the time, so you wanted to get your margins really, really small and just treat what you had to treat, which is the gross disease, and that's great, right? Because you can deliver these, big dose of radiation, you can carve around duodenum, and you're going to give a lot, you're going to spare toxicity because a lot of tissue is going to get radiated, so that's great. But I think we've learned over time, if that's your principle, is you're trying to use the margins as little as possible. Oh, my thing isn't working anymore. It's maybe out of battery. There have been data showing that you are now potentially risking getting more marginal failures. And this was a study from China that had like 500 local recurrences after pancreas SBRT. I can't imagine how many patients they treated to get 500 local failures, but they did. And they categorized and mapped out where these failures were happening. And I'm sorry, but it actually doesn't show up well. Hold on one sec. Hold on one second. I'm going to fix this. Except my mouse. Uh-oh. Oh, someone's controlling my mouse. Can I? Okay, well, never mind. The point is it's here. You could see that there's a significant number of failures of the celiac, SMA, both the portohepatis, the splenic, and what you can't see kind of is blocked is the retroperitoneum. And you could see that the distance from where the failures were happening relative, they could be as far as a centimeter away. So it shows that there's a lot of microscopic disease around the tumor that you're probably at risk of missing if you're just going to treat the gross disease. This was further kind of supported by this prospective phase 2 trial from Cincinnati where investigators gave people preoperative chemo and chemoradiation. They gave the chemotherapy and then SBRT radiation. And they just treated the primary disease at first, and then they took them to surgery. And what they found was that there was a pretty high number of local failures in the first 8 patients they treated. They had 2 local failures, and so the investigators decided to add a 25 gray and 5 CTV that included the entire head and body of the pancreas, the SMA, and the celiac to make sure you cover some of those areas of microscopic disease. And they found that when they did that, there was a decrease, it's at the bottom there, a decrease in the number of local failures when they added that CTV. Overall, it's still pretty high. I don't know why it's so high in both arms, but the point is that it looks smaller. And then when they did this dosimetry analysis, they showed that the majority of the local failures happened in areas that were underdosed or received low doses of radiation. So this, to me, shows some kind of real-world data that perhaps adding a more elective volume may be useful. So at Stanford, at this time, we started thinking maybe we should start adding this elective nodal volume. And so we started with this 25 gray and 5 CTV that covers all of the nodal drainage regions of the pancreas. And we used 25 and 5 because that's what's typically used in rectal cancer, and we know it's tolerated well, so that was what was decided to be used. And you could get plans that look like this, so you could still treat 40 gray, that was our protocol there, to the tumor, but you can still get a 25 gray dose to the elective nodes. And after a few years, we decided to look at our data, and we looked specifically at sort of patterns of failure, and what you can't see too well, but so in the top middle, that was the local progression rates, and you can see that when you included patients, so what we did was we had 50 patients treated with elective nodal radiation, and we did a matched control comparison of 100 patients that before that did not receive elective nodal, and we compared them. And so if you see in the top middle, that is the local progression, you can start to see a separation of curves. Patients who had E&I had lower rates of progression. That was not statistically significant. In the next one, C, it was regional only, and you can start to see that split. That was not statistically significant. But if you look at D in the bottom left there, that is both local regional, and that was a statistically significant difference as far as local regional failures. And this is just showing the same thing in number form. So you can see local regional progression was double when you did not use E&I. And so we cut that in half with the addition of E&I. So if you're going to use E&I, where do you want to treat? And so there's this concept of the triangle volume that radiation oncologists have borrowed from surgeons. It's the concept of where there's these extrapancreatic neural tracts where the cancer cells can follow, and it's this triangular space that's sort of bounded by the celiac artery, the common hepatic, the SMA, and the portal vein / SMV. And so this is kind of considered where we should probably be focusing our elective nodal regions should we do this. And so just recently, I think it was just this year, Nina Sanford and a group of folks published this Energy Oncology International Consensus Contouring Atlas about where we want to cover if you were to do so. And you can see for head and neck and proximal body tumors, you want to add a 1 centimeter margin to your gross disease. You want to trim off luminal structures, cover the celiac and the aorta to the bifurcation, and add a margin, cover the common hepatic until the GDA, include the fat space between the aorta and IVC, laterally include the medial portal vein, and then include the SMA and SMV down and ended at the first jejunal branch. And then for the distal and body and tail tumors on the right side, they had very similar kind of recommendations as well. So moving on to dose, so that's the topic for elective nodal, but moving on to dose, obviously the proximity of the tumor to the GI luminal organs is what, is a limiting factor. And I think people that do SBRT, they face these challenges when you're trying to align them on the table. Suboptimal cone beam CT really makes it hard to make sure that you are aligned properly. You can see just kind of how, that's the planning CT on top and that's the cone beam CT on the bottom. There's no internal imaging during treatment, so you just kind of have to have faith, but you don't really know because the patient's breathing and could be moving. And then you cannot modify or adapt the radiation dose distribution to account for internal anatomic changes. So, this is kind of where MR-Iinac and MR-guided radiation has really shown potential to improve outcomes. The advantages are the ability to see the various anatomic motions, accurate soft tissue imaging, you can do accurate real-time gating, on-table adaptive treatment is possible, and you have onboard functional imaging as a potential option. And this is an example of, you have a planning CT, and you have the MR simulation, or MR scan, and you see that, there's just a lot of daily variation that you don't account for. And so, basically what you can try to do is you can try to adapt. I showed this slide earlier, but you can essentially, if you look, I'm sorry, again, there's no laser, but, A is the planning MR, B is how the MR looks on the day of treatment. You can see that the bowel, that green structure, has now moved into your target. And so if you were to deliver the planned dose, you would obviously probably wind up overdosing that bowel. So C is you can modify the dose and now keep the dose away from that bowel. And you can see on the DVH at the bottom, you can get improved PTV coverage with the adaptive, and you can improve your small bowel dosimetry as well. So ideal candidates for liver SBRT with MR-Iinac, they can follow instructions. Patients that don't have severe claustrophobia, just know that probably the bore size is a little bit smaller, so patients that are very large and overweight probably can't fit. They have to be able to hold their breath and stay still for extended periods of time. Obviously, they can't have non-MR compatible electronic devices or foreign objects. And additional considerations, it's a resource intensive. There's a whole workflow that you have to, adjust for and design. The machine is expensive, they have to factor in as well. And then, of course, you only have step and shoot IMRT, which may not be as good as VMAT, which is what many of us use these days. So this is kind of what has been sort of the standard for those that use MR-Iinac. You would get a CT sim as well as an MR sim. And then you would do your planning as usual using their treatment planning system. On the day of the adaptive treatment, you would put them on the machine, get the position review with an MR, and then you would then begin contouring, where that target and the OARs are for that particular day. And then at that point, you have to decide, do I want to give the planned dose or do I want to modify? And if you want to modify, you would use those volumes and then do a planned reoptimization. You would do plan QA, and then you'd hopefully be ready to go and you'd do the treatment. But this planning process, this whole process right here, could be like an hour. And so that's something that you have to factor in when that patient's sitting on the table for a long time. MR-Iinac planning, so it's primarily the technology is step and shoot IMRT with 6X. It can lead to longer delivery times, more dose streaks. You can see all the streaks that are there relative to more of a VMAT plan that many of us are used to. But here's the benefit, as I mentioned before. Again, perfect example of a tumor, and then you can see how the stomach now moves into the target, and you can basically improve the dosimetry of the GTV. You can get it, if you were to give the plan that day, or the predicted plan, it would be 93% coverage of the PTV, but you can get that up to 100. And then you can see here the stomach V30, you can see the dose, unfortunately would be, much higher with the predicted plan, and so you can get that back down to, 0.05 cc's. There's data on this, which you'll probably hear a little bit more about from Dr. Koong's talk later. But the SMART trial was this phase 2 trial that was led by investigators at the Miami Cancer Institute. But they basically treated patients. They gave a dose of 50 gray and 5 fractions, which is a BED of 100, and they applied all of the principles of adaptive replanning if needed. And ultimately, they found that the local control was very favorable at 78.2%. Actually, I think it was at 2 years, actually, with the survival that was pretty encouraging at 40% at 2 years. But most importantly, what they found was there were 0 grade 3 or higher toxicities attributable to the radiation treatment. So that was considered a very encouraging and positive study. There are other ways, of course, that we can give ablative radiation. SBRT is not the only way, and I think this showed up in some of the people who raised their hands. There is also hypofractionated ablative radiotherapy, which has been, some investigators, particularly from MSK, have really pioneered and developed. And so the goal is that you really want to try to get a BED close to 100, but you want to fractionate it. So their protocol was that they treated, for tumors that were within 1 centimeter of stomach and bowel, they would treat 75 gray in 25 fractions, and if they were far enough away from the stomach and bowel, they would give 67.5 and 15 gray. And they showed, very encouraging, very similar results. 1 year progression, cumulative incidence of progression, 17.6%, 2 years was 32%, and survival median from diagnosis was 26.8 months. So the question is, well, how do they compare? And this was actually presented at ASTRO, where they did a retrospective study comparing the two, hypofractionated ablative radiotherapy versus SMART. And yeah, of course, they included a CTV in this, so I'll just kind of skip through this real quick. But the point is that what they found ultimately was that SMART actually was associated with better freedom from local failure, although no major significant difference with the other disease endpoints of freedom from distant failure or progression-free survival. There was this kind of, borderline significant difference in overall survival, but probably not necessarily something that we might necessarily attribute. But I think the big finding is it seems like SMART, SBRT seems to be associated with better freedom from local failure. And then the next, this is just practical point, this is just shows, this is the time on the table if you were to use MR-guided Iinac. This is data from Stanford. They went from kind of an older treatment planning system to their new A3i, which is the latest adaptive software. That does have improvements, but you can see, they went from 1 hour, 3 minutes down to 48 minutes on average. But just generally speaking, that should give you kind of a sense of the amount of time that you spend on that table. So that's what I have to share. I didn't get into specifics about the patient. We treated the patient with 40 gray and 5 with SBRT. The patient, we tried to get them to surgery because we thought it was borderline. The patient was not able to get to surgery. And interestingly, 2 years later, progressed, and locally only, and then found a surgeon to remove it. And for whatever reason, that's what happened. And the patient actually survived for like 2 years after that. So it was actually quite an interesting story. I think that's my last slide. So happy to talk about that a little bit and see what people thought. Any reaction or any thoughts? Albert, certainly I'd love to get your thoughts first, if you'd like.
Yeah, so actually I'm covering some of this in my talk, which is immediately after this, so shameless plug for another session after this. Yeah, so at MD Anderson, we have the data that Dan showed, the SMART trial was using the V-Ray machine, which is the low field magnet and Iinac. We have the Unity, which is the elective version. It's a 1.5T magnet and a linear accelerator. The only recently has Electa put forth the ability to do respiratory gating or breath, any kind of respiratory correction. And I think that's a key point, when you're doing SBRT, is if you don't correct for the respiratory motion, if you're just using free breathing, the tumor is going to move as much as 1 or even up to 2 or more centimeters in soup direction. And so if you don't correct for that motion, you have to put a much larger margin around there. And the bigger your margins, the bigger your PTV is going to be. And so if you put too much of a margin, you end up treating probably more normal tissue than actual tumor. So I think the key to any kind of SBRT is that you want to minimize the margins using some kind of respiratory control. It could be, like right now what we use is a belt that limits the diaphragmatic motion. So that works pretty good. The Unity just got upgraded to be able to do respiratory gating. I actually haven't done a case using respiratory gating yet because it's still a little bit clunky. And Dan says, it takes about an hour. I think it takes an hour if you are under optimal conditions using the Unity. But the workflow, I think, on the V-Ray is maybe a little bit better, but on the V-Ray is a little bit better. But on the Unity, I would say it's probably closer to an hour and a half to really do true adaptive. So that's probably the commitment. But you're talking about 5 fractions. I think dose escalation, we talked about this a little bit. Dose escalation, although there is data supporting that, the SMART trial went to 50 gray in 5 fractions, and that seems better than historic controls. But remember, in the SMART trial, it was induction chemotherapy and up to, I think it was 4 or 6 months. And about half the patients got gem and Abraxane, and the other half got FOLFIRINOX. And we know that both of those regimens are better than gemcitabine alone. But if you look at the older data, I'm referring to the data from Stanford, that was in the gemcitabine era alone. And in the multi-fraction trial that we did at Stanford Memorial and Johns Hopkins, that was the first multi-center trial. We went to 6.6 gray times 5. But that was in the gemcitabine era only, and we use SBRT up front. So you don't have the benefit of selecting patients for 6 months, getting the best of those folks, and then looking at their survival. We use SBRT up front. So if you kind of take into account all of those factors, it's not clear to me that 33 gray in 5 fractions is really that much inferior to 50 gray in 5 fractions, given that you have all these other caveats. I think the HART, or the hyperfractionated radiotherapy approach, I'll go into this a little bit in my talk as well, but that 15 fraction regimen, 6750, we use that sometimes at MD Anderson as well, and we will select that fractionation versus our standard off protocol dose now is 40 gray in 5 fractions. Depends on the location of the tumor. So sometimes you want you want a minimum dose to all the tumor. Other times, depending on the location, you may not be able to achieve that. So in that HART fractionation, it's really the devil's of the details. Because if you're close to bowel, what happens is we usually put a PRV around there and then subtract the PRV away from the PTV and carve that dose out. So you end up, in some ways, underdosing a chunk of the PTV. So you can't achieve, 95% of the volume to 100% of the dose, which is our typical, goal. So in that situation, you end up underdosing some of that.
Yeah.
So I think I've got 5 minutes left. So I'll just wrap up this point. So it really depends on what you want to achieve, right? Do you want to achieve the 6750 to majority of the tumor, or are you okay with underdosing part of it? With the SBRT, you also have some similar constraints as well, and sometimes it's more desirable to use more of an SBRT kind of a dose. And then the elective nodal thing, I agree with what Dan said about that. So.
Just curious, does anybody, if I ask that question again, who would cover elective nodes? Can people just raise their hand? Anybody change their mind, or are they still feel confident in their answer from before? Would anybody change their mind? Okay, so I saw one hand. One hand, yes. All right. I don't. 5 minutes. You want to go through your last case?
Yeah, I can just show an example of it. It's really fast.
Or you want to use?
Oh, yeah. Is it just following this? Oh yeah. Okay. So this is actually not one of my patients. This is a colleague of mine's. A patient presented with this kind of a massive tumor. And you can see, I don't know if this. Okay. Okay. Well, you can see that there's more tumor than there is normal liver, right? In the, sort of in the lateral aspect of the liver, you can see, some normal parenchyma there, but most of this is tumor. And biopsy showed that this was a massive cholangiocarcinoma. So normally, and when I was at Stanford and we didn't have protons. This would just be a palliative, maybe chemotherapy case, and we wouldn't even think about using radiation. But because we have protons, this is what was done. So this was using a passive scatter approach, but we're able to treat this volume to 60 gray in 15 fractions and trying to keep all the luminal structures less than 45 gray. And then we use kind of the same principles as when we're doing liver SBRT. We try to spare 700 cc's of the liver, and this is based on surgical literature that you sort of need about 700 cc's of functional liver to be safe, and we try to keep that below 24 gray. Because we're running out of time, I won't go much more into detail about this, but the key constraint is to spare the liver as much as possible. And so this is the DVH, and so it's probably a little bit hard to see from the back, but you see the arrow is pointing to the liver minus GTV volume there, and we're able to keep 700 cc's less than 24 gray. The other constraints were easily met. And then this one kind of has a happy ending because this is now 4 years later, and the patient is still doing well, NED. And we're actually putting together a series of these patients now that we've treated. Ethan Ludmir is going to be the lead author on this study, but he calls these, he's coined the phrase supermassive tumors of the liver. And so we've developed a collection of these kind of liver tumors. And the interesting thing is those that are out many years, you do see a little bit of regeneration of the normal liver. It's hard to appreciate just from one cut here, but this is all dead tumor, and it's kind of evolving. And apparently, at least in this patient, he's alive and well 4 years later. So I think we are out of time because, okay, 1 minute. So any thoughts or questions, and how would you all approach a case such as this?
How do you decide when to use protons? Like, does it have to hit a certain size before, or would you treat all with protons?
Yeah, it depends on where you're trying to treat. If it's kind of a more medial tumor, sometimes even if it's smaller and you're trying to spare bowel or colon or stomach that might be in that area, you don't. If you use a proton approach, you might be able to spare more of the bowel and the GI structures because you don't really have much of exit dose. So I think location matters more. I mean, obviously, size does matter at a certain point, but I think location matters more. And I think we're still kind of learning on how best to use protons, but certainly I think the adjacency of OARs I think is key. Recurrent tumors, sometimes we will retreat using protons again because you've maxed out the normal tissue constraints. And then just also for practical reasons too. Sometimes our insurance authorization process doesn't allow it, so that you can't. But the ones that do, then we try to use protons when possible. In this case, yes, yeah. For most of so Astra has different guidelines, and this is in the group of tumors, liver tumors, especially big, large liver tumors, that generally we haven't had trouble getting coverage for insurance for that. Okay, I think this means that we are at time. So thank you all for coming. This is really a great session.